afternoon. I'd like to thank you for seamlessly connecting to talk about the fecal microbiota with the discussion of intestinal gas. So thank you for tying all these sessions together. Thank you for that. So my name is Leslie Fecher. I'm one of the medical oncologists here at the University of Michigan. And again, thank you for joining us today. So in medicine, we have a lot of attempts to try and, I need to move my camera. One moment, I'm sorry. Okay, I think that's pretty good. All right. So in medicine, we try and understand what happens in life to the human body. And I think as all of you would agree, the human bodies are all distinct and our human bodies change over time as well. And I think the cancers are all distinct as well, and they change over time. And so this is a flawed attempt to try and understand what's going on. And we tend to try and recognize the patterns and we try and recognize the majority of things. But I think it's also important for us always to look for the unique aspects and realize that not everybody is going to fit into the same paradigms. And so this is where I think it's really important that we always emphasize that our goal is to understand certain things, but then change and adapt whatever the recommendations are to each individual patient and each individual cancer situation. And I'm going to reflect back on something that I learned as a fellow with one of my attendings. And it was actually talking about a different kind of cancer with a very extensive classification system of trying to figure out, and we had a discussion about one patient's cancer, trying to figure out how are we going to classify it? What are we going to call it? And how are we going to treat it? And it didn't quite fit into any of the classification systems we had. And he started laughing and he said, you know, the cancer doesn't care what we say it is. It's going to do whatever it wants. And so I think I always like to start these conversations saying we use a lot of language, we use a lot of classifications and sometimes labels, all in an attempt to try and describe and understand what's going on. None of them are perfect. There are flaws and limitations to all of them. But again, all of it is with the intent of trying to understand. And so my task today is to talk about some of the unique aspects of melanoma, both subtypes, unique patient populations, and unique treatment toxicities. These are my disclosures. So melanoma, back to the basics, I always like to start there, is a cancer of melanocytes, your pigment-producing cells. And for the most part, the vast majority, at least in the United States, is of the skin or cutaneous origin. And most of the data that we have is going to be reflecting mainly on skin melanomas. And so we talk about invasive when it goes beyond melanoma in situ. And for 2022, it's just under 100,000 new cases in that year. And when we add in melanoma in situ, that's approximately another just shy of 100,000 cases per year. And the incidence has been rising. And this has been going on for several decades. And the top graph with the blue dots are in men, and the lower one is in women, but I think it's very clear to see that it continues to rise. And the risk factors sound familiar to most of us. I'm going to hide my panel if possible. There we go. Ultraviolet light exposure. This includes both the sun as well as indoor tanning. Numbers of moles, the higher the number, the higher the risk in presence of atypical moles. I want to emphasize family or personal history, and this is going to be a recurring theme. If there is a family history, anybody in the family with any kind of melanoma, that's important to share and be aware of. Skin type, hair color, and eye color, immunosuppression, and then familial melanoma syndrome, where there's actually inherited risk, albeit this is the minority of cases. And this is our schematic when we talk about kind of the top 10 kinds of cancer in the US. Melanoma is number 5 for men and women and has been for a while. And when we think about the estimated lifetime risk, now this is a label we use, non-Hispanic white Americans, 1 in 27 men and 1 in 40 women in their lifetime will be diagnosed with melanoma. So what about some of the less common subtypes? So we'll start with skin or cutaneous melanoma. 1, we have acrolentigenous or subungual melanoma, and we often abbreviate that ALM. This is something that can start on the palms and the soles of the hands and feet, as well as under nail beds. And this is approximately only 1 to 3% of all melanomas. It can be seen in people of color, and this is really important and going to be a theme for this talk as well as unique populations. When we think about the proportion of all acrolentigenous melanomas out of all cutaneous melanomas, or all melanomas, in certain groups of patients, in whites, non-Hispanic whites, it's only about 1%. But when we start thinking about people who are Black, that is as high as 33.6% in this particular report, 23% in people of Asian or Pacific Islander background, and in Hispanics, 9.3%. Diagnosis, unfortunately, often is a little bit later and sometimes at higher stages because, again, this is a less common presentation. So when we have something that's less common, people have sometimes less seen it, both the physicians and healthcare providers, as well as patients. Treatments, if this is located on a finger or a toe, sometimes that actually involves digital amputation, not large amputations, but digital amputations. Because again, I know we talked earlier about wide local excisions, and while we debate how much, we do know we need some distance from the tumor to try and remove it. Let's talk about another subtype within cutaneous melanoma, desmoplastic. And some people have heard of this and other people have not. This again is a rare one. And we think about this somewhere in the range of 1 to 4% of skin melanomas. And this is typically going to be not pigmented, meaning it would be the flesh color it starts on. Sometimes people use pink and red, but that is really going to be determined by the pigmentation of the background skin. It can present as a firm nodule. It often involves superficial nerves in the skin. And it's often in what we call the head and neck area. And it's a bit more common in men than women. Risk factors include advancing age, as well as ultraviolet light exposure. And the treatment is fairly similar to other cutaneous melanomas. So now we get to go beyond the skin and we start talking about other parts of the body that can have melanomas. Mucosa is the lining of various body parts. So we think about the lining of the mouth or the lining of the nose, the throat, the sinuses. This includes intestinal mucosa, as well as the vaginal area in women, urinary system in both sexes. And melanocytes are scattered throughout these mucosal surfaces. This is approximately 1 to 2% of melanoma cases in the US when we factor in all melanoma. Now, in some countries where cutaneous or skin melanoma is less common, mucosal melanoma is actually going to be a greater percentage of the total melanoma cases. The annual incidence is typically about 1,000 or less here in the US, and the incidence is not rising at this point. We can see this also in people of color. We see this a bit more commonly in women than men, and it's more common as people get older. And as one can imagine, this is challenging to diagnose. As you can imagine, sometimes these are in parts of the body where you could actually see it, such as if it was on the roof of the mouth and you could see a dark pigmented area, but some of these are not pigmented. They can be flesh colored as well, if that's how we want to describe it. And sometimes they can only present with symptoms that may seem like regular things like runny nose and sinus infection. Now, again, I want to emphasize these are quite rare, but obviously we're talking to a biased party here where we all know this exists. And we don't really understand why these happen. Clearly, the ultraviolet light exposure is not playing a role for these. The treatment, when we talk about the primary tumors, again, complete surgical excision is a goal when we have just primary tumors, but you can imagine in certain parts of the body trying to get completely around this and get clear edges can be a challenge, if not impossible. And so sometimes radiation to those sites plays a role. When we talk about more advanced mucosal melanoma, these typically can behave a bit more aggressively than cutaneous or skin melanomas. And they may do better when we think about combination immunotherapy as opposed to single agent immunotherapy. We rarely see BRAF mutations in this group of patients, but KIT mutations, another gene that can be abnormal in some melanomas, can occur. Now we're going to jump to another part of the body, ocular or uveal melanoma. And again, melanocytes are present throughout the eye. In particular, we think of what we call the uveal tract. So the choroid, which you can see down here, the ciliary body, as well as the iris, pigmented part of the front of the eye. And then we can also have melanocytes in the conjunctiva, and we consider these just a little bit different than the uveal tract melanomas. This is a little bit more than mucosal typically in the United States, but still quite a rare tumor. Annual incidence is typically less than 2,000. And the incidence for this is stable as well. Men a bit more than women, albeit not very much difference. More common as people get older, typically we think of the 6th and 7th decades. Risk factors, so family history is important again for us to consider. Genetic mutations can be seen and pass through the family. BAP1 is something that was identified in the last several years and is better understood now. And light eyes and fair skin, albeit I am going to reiterate, this can be seen in people who have darker eyes as well and darker skin pigmentation. Treatment, when we have primary tumors, this often involves a form of radiation, something we call a radioactive plaque that is placed over the tumor in the back of the eye. Or sometimes if the tumor is large enough, it involves surgical removal of the eye. Monitoring with a specialized ocular oncologist is very important, and that continues long-term. And ultrasounds of the eye, which is not something most people have ever heard about, is a component of their care. Gene expression tests can sometimes provide what we call prognostic, or trying to predict the future information for these. But again, this is important to remember that testing is only as good as what we call the validation that's been done. And just because we have a test doesn't always mean it's helpful. And surveillance imaging often involves looking at the liver or assessing the liver, both with scans as well as blood work, because when this moves, it typically will like to hone to the liver. And this is something that we in the melanoma field continue to try and understand why it does that. These, again, can behave more aggressively than skin melanomas. We rarely see BRAF mutations, where conjunctival would be an exception to that. And they typically respond less well to immunotherapy. Tebentafusp is a new agent that was recently FDA approved. And this is actually the only agent that is FDA approved specifically for metastatic uveal melanoma. And this is a nice addition to our toolbox, if you will. However, it is limited to people who have a specific kind of white blood cell. We use HLA typing. And basically, this is a blood test to figure out, because the medicine itself is designed to recognize it in these people who have that. So that's independent of a cancer diagnosis. It's just the makeup of your white blood cells. Liver-directed therapy is also something we consider using in uveal melanoma sufferers, because it can sometimes be disproportionately affecting the liver. So this could be a variety of different interventions, such as radiation, embolization, and that's a large topic in and of itself, as well as surgery. There are also mutations in genes, we call them G proteins, GNAQ and GNA11. And so while we don't see BRAF mutations, sometimes a single medicine, a MEK inhibitor, may play a role in trying to alleviate some of the progression. So now I'm going to switch a little bit to unique populations, and we've been talking about this a little bit. Melanoma, without a doubt, from a skin standpoint, is predominantly affects people, Caucasian Americans or white people in general. However, it does affect people of other pigmentation. And so here, if you look at this, this is data from the CDC about incidence, and this is the rate of skin-only melanoma per 100,000 people. And you can see, obviously, in the white column, that's a large amount, but approximately 1 per 100,000 Blacks, Alaskan Native and American Indian at 5, Asian and Pacific Islanders 1.2, and Hispanic 4.6. And some additional schematics showing similar things. This is broken down, and again, this is rate of new cases per 100,000, but distinguishing between men and women. And you can see when we think about all races and in whites, it's a bit more common in men compared to women. But when you look at the rates across the board from men and women and other groups, that tend to be fairly equal. I think this is also important to document, again, the rising incidence, which we've already talked about. Again, this is the same kind of concept of rate per 100,000, where this line is in whites. The incidence in Asian, Pacific Islanders and Blacks is fairly consistent and flat and not rising, but it is rising when we look at the American Indian, Alaskan Native population, and importantly in Hispanics. We can see in people of color both skin and non-skin melanomas. The diagnosis is, as you can imagine, less expected, both from sometimes the physician perspective as well as the patient perspective. These often can present later and in more advanced stages, and unfortunately, the outcomes have been worse. Rising incidence, as we talked about, is important, and again, we need to tailor what we do to try and address this increase. Action items, in my opinion, within our community is to improve melanoma awareness. And this is both for patients as well as for physicians and other healthcare providers. I think we need to improve the concept of UV protection, awareness, and knowledge. And this includes avoidance, not just sunscreen. Indoor tanning has been a significant harm and continues to be. We need to improve access to resources, and in particular, medical resources, physicians and dermatologists, which sometimes I think everybody can appreciate. We have not enough dermatologists sometimes for the needs that we have. And I think we also need to think about better resources. We need resources inclusive of all skin tones. This is something that can be a challenge if you've never seen some of these skin lesions appear. They can look different on different skin tones. And I think we need to meet people where they are. We need to be able to bring education and awareness in different languages and into different settings. Another unique part of melanoma is the age range. This affects the very young to the very old. For women, the incidence is higher in the young, and we think this plays a role in sun behavior as well as indoor tanning behavior. For men, the incidence increases with age. The incidence in young adults in multiple reports since about the last 10 years appears to be decreasing, and we can hope that that has to do with some of the campaigns trying to educate people about ultraviolet light exposure. But indoor tanning use is greater risk the younger you are. And one statistic is that there is a 60% higher risk of melanoma if you start indoor tanning use before the age of 35. Many people are starting it in their teenage years. If you think about kind of incidence, when we think about people aged birth to 14 years, melanoma comprises about 1% of cancers. It can affect a very young pediatric population. From age 15 to 19, it's about 3% of all cancers seen in that age range. From age 15 to 39, it's actually the third most common cancer. This is more frequent than what you saw for the general populations, where we talked about it being number 5 for men and women, for all comers and non-Hispanic white Americans. And even as we get older, you can see in a population greater than 85 years old, it is still the number 5 cancer in men. However, it does decrease in incidence for women down to number 8. I'm going to switch again. We're going to talk a little bit about immunotherapies. And so you guys are all experts. You are already aware that this is trying to help the immune system, the Pac-Mans, get after the cancer. And we have a variety of different topics, but sometimes for the most part, we spend a lot of time talking about what we call checkpoint inhibitors most recently. So this is just one type of immunotherapy. And the most common ones you're going to be hearing about, as you already have, are the PD-1 inhibitors, nivolumab and pembrolizumab, CTLA-4 antibodies, ipilimumab, and relatlimab, the newest agent on the block that is currently FDA approved in combination with nivolumab. So side effects, this is a personal passion to educate and make everybody aware as much as possible. The majority are going to be due to stimulation of the immune cells that then attack normal parts of the body by accident. We like to call it collateral damage. It's similar, but really not quite the same as autoimmune conditions. And these are unpredictable. We don't know who's going to get them yet at this point in time, but that is a hope that we will be able to predict that better in the future. We don't know when it's going to happen. It can happen early, it can happen late, it can even happen after you stop getting active treatment. And how severe? They can range from very mild and irritating and annoying to life-threatening. Typically, we think about holding treatment for a period of time, sometimes temporary, sometimes permanent, depending on the side effect, and giving steroids such as prednisone. And occasionally we need to use additional medications. But these can get worse if they are not diagnosed and treated properly. And we think of them mostly as short-lived, however, there are some exceptions. So the common things we see: fatigue, skin inflammation. You already heard a little bit about vitiligo today. That is by definition harmless, but sometimes cosmetically is not what people enjoy. Bowels can get inflamed, and typically the large intestine as well as the small. The liver can get inflamed, endocrine glands, lungs, the eyes. But what we don't talk about sometimes, or it's harder for us to understand, are some of the more less common and sometimes more severe toxicities. And that's where I think it's important to reflect. Any of the toxicities of any part of the body can be severe enough to cause hospitalization. Some will require additional immunosuppressive medication. So in Dr. McQuaid's talk, you heard about a patient with colitis that had multiple medications, immune lowering, trying to get it under control. And so that's not common, but it is possible. So we think of a severe blistering rash. A blister on the skin is a reason to call us when we talk about the skin. The bowels can get very inflamed, and sometimes inflamed enough that they actually have a hole in the intestine or perforation. Severe liver inflammation. The kidneys can get inflamed too. This is less common, but we do see it. Insulin requiring diabetes, again, very rare, about 0.5%, but obviously this is a big deal and this is one of the more permanent side effects. The heart can get inflamed, myocarditis, blood vessels can get inflamed, vasculitis. Nerves, brain, spinal column can get inflamed, and these are quite significant ones. And then blood cells, bone marrow can get affected by these agents. Some of these toxicities, given the severity and the location of the body being impacted, may prohibit additional immunotherapy. This brings us to another unique population or group of populations we see in the melanoma world, are people who already have pre-existing or previously diagnosed autoimmune conditions now coming into the cancer world and melanoma world. People who have had an organ transplant, such as a kidney transplant, and those who are on immunosuppressive medicines for something other unrelated. Examples of autoimmune conditions I think you're familiar with: rheumatoid arthritis, Crohn's disease, ulcerative colitis, myasthenia gravis. This is a large, varied group of diagnoses and manifestations in patients. So drawing conclusions can be challenging. We know that immunosuppression by definition increases the risk of all skin cancers, not just melanoma. Most of these people are not eligible to participate in clinical trials with immunotherapy simply because of the concern of causing harm. We think it's unacceptable risk. So that makes it harder, however, to better understand who might be safe for treatment and who isn't. We have limited data from that standpoint. And I tend to approach this, and I think both of us do, on a case-by-case basis. What is the underlying condition? What parts of the body are affected, and how much are they affected? Do they require current treatment to keep this underlying issue under control? And is that something that we can minimize or lower to allow the immune system to recover just a little bit? Will the immunotherapy work against the melanoma? In a very immunosuppressed environment, unfortunately, our drugs are not going to necessarily behave the same way. So all that wonderful information about benefit may not apply when we have a very different body. What would be the worst case scenario? Is this something that we could fix, or is this something that could potentially, unfortunately, threaten maybe their transplanted organ? And that's something we have to think of in advance. Proceed with caution is my motto for most of life, in all honesty. And this is an ongoing area for research and study. Last but not least, we have the BRAF/MEK inhibitor therapies, and we usually use these together. And I think you're familiar with some of the names of the BRAF medicines: vemurafenib, dabrafenib, and encorafenib, as well as the MEK inhibitors, cobimetinib, trametinib, and binimetinib, but occasionally we use them as single agents. You're familiar with a lot of the side effects of migratory aches and pains and rashes and sometimes fevers and chills, but there are some less common side effects as well that are good to be aware of. One, we can have secondary cancers with BRAF inhibitors, and most of the time we start talking about skin growth, sometimes benign, but we can also have skin cancers where squamous cell is common, but occasionally basal cells and melanomas. There are also very rare reports, but important for us to talk about, of secondary cancers of other parts of the body. So there have been descriptions of the pancreas or head and neck cancer or intestinal cancer in some of these patients. And the mechanism we can speculate on, but is not completely understood. Again, I want to emphasize that's very rare. We can occasionally see hypersensitivity reactions, which means the patient's body is exquisitely sensitive to these medicines. And sometimes that can present as a severe rash with liver or kidney problems or in other ways. And sometimes we can see neuropathies or nerve damage. With MEK inhibitors, we can see eye side effects. And so an eye exam is often a part of people's initial evaluation, if not early on to treatment. We can see muscle damage, which is, again, temporary, but important for us to be aware of, and that can affect the kidney if there's a large amount of muscle breakdown. We can see heart failure. So again, echocardiograms, typically ultrasounds of the heart to monitor the ejection fraction or squeeze of the heart, are a part of follow-up. And then we rarely can see lung inflammation or pneumonitis. So in summary, melanoma affects many different people in many different ways. Improving awareness and knowledge of melanoma and its treatments and their side effects, to me, is critical. I think it's important to think about seeking prompt evaluation for concerning skin lesions. It's okay to be wrong, even if it's something you get reassured about. And then other symptoms that could be concerning for these less common melanomas, but unfortunately they can be tricky to try and understand. And I think it's always important to understand exciting medicines are available and others continue to be evaluated in clinical trials, but ongoing monitoring and management of side effects is also an area of ongoing study. Thank you.